We will today discuss changes about the plasma exchange in the critical care setting. And my agenda will include short introduction about the critical care setting and the clinical indication, and the 3 cases about the different indication for the plasma exchange. The critically ill patient, it is more likely to experience hemodynamical instability and also coagulation disorder and electrolyte abnormality. And the adverse events of this plasma exchange occur more frequently with the first procedure, especially in the patient with certain diagnosis, especially the presence of autonomic instability and the low starting hematocrites, which increasing the risk of hypotension, and also when the plasma exchange. As general, plasma should be avoided unless it is required to correct the complement or coagulation factor deficiency or needed to prevent the bleeding complication. And also, don't forget the plasma exchange remove the pharmacological agents which reduce the critical medication to the subtherapeutic level, such certain the antibiotic. But don't forget also it is favorable in some drug overdoses. In patients who require intermittent hemodialysis and the plasma exchange at the same setting, in general, we must to perform a plasma exchange first, followed by the intermittent hemodialysis in order to correct the electrolyte acid-base disturbance and excessive fluid tissue. And in patients that need the CRRT with the plasma exchange, discontinuing the CRRT therapy during the session of the plasma exchange, or the another opinion may run the two in the same setting simultaneously, either in parallel or what is meant by the series circuits. This is what is the parallel and what is the series circuits. In patients removing the ECMO, and it is done in our faculty, including the extracorporeal membrane oxygenation with the special consideration and the modification, the plasma exchange can be done simultaneously while the patient is connected to the ECMO. And when using the rituximab, it is recommended to perform the plasma exchange 24 hours after administration of the rituximab. This is the short introduction and the bullets, especially in the critically ill patient. And according to the ASFA guidelines and the Japanese Society on the 21, which review the indication for the plasma exchange, they defined as category 1, which includes this is either the standalone first line therapy, either used alone or in combination with other therapy. And the category 2, which is considered as the second line therapy, either as a standalone or in conjugation with other therapy. And the category 3, this is personalized to optimizing the rule according to patient by case. And the category 4, this is to be absolute contraindication or relative contraindication because it is not effective or harmful for the patient. In the critical care setting, there is some difference. There is absolute, this is as the category 1, with evidence as the first line, and relative, which is evidence as the second line and according to case by case, and the rescue or the salvage therapy, which have the limited evidence but the benefit, but it is to be risk and the benefit for each case. Category 1, anti-GBM, ANCA-associated vasculitis, catastrophic antiphospholipid, hyperviscosity syndrome, thrombotic thrombocytopenic purpura, acute autoinflammatory demyelinating disease or Guillain-Barré, myasthenia gravis, and acute liver failure. Category 2, either the cryoglobulinemic vasculitis, acute disseminating encephalitis, autoimmune encephalitis, or the thyroid storm. And the category 3, which is case by case, thrombotic microangiopathy, infection associated, and HELP syndrome, heparin-induced thrombocytopenia, and the hypertriglyceridemic pancreatitis, and the sepsis with multi-organ failure. This is category 3. It is case by case. It is not an absolute contraindication. And when to go to one of the first case that we discuss today. This is a 40 years male patient, taxi driver who used to smoke 20 cigarettes per day for the previous 10 years. And he was presented to our ERs with coughing of blood. 3 months before the presentation to the ER, he developed the vague symptoms in the form of fatigue, reduced appetite, and weight loss. And joint pain, not associated with the swelling or limiting mobility, tingling and numbness in the foot, and his long tiring. And the routine investigation reveals that normal, apart from mild normocytic normochromic anemia with blood hemoglobin 10.5 and elevated ESR. And 2 weeks before the presentation to the ER, he became feverish, unmeasured, and suffer from cough with productive of the small amount of the blood-tinged sputum with the progressive shortness of breathing. And 1 day before admission, there is a few cc of the bright red blood that is rushed to the ER at our hospital, and there is no any cardiopulmonary, gastrointestinal, urinary, or skin manifestation, and he was receiving a regular medication that he was, and he is not known to be allergic from anything, and there is no significant past history apart from recurrent sinusitis in the few months. And the family history, it is not contributed. Upon examination, the patient is quite normal, apart from he was in the respiratory distress, and the temperature is 37.8, and the respiratory rate is 30 per minute, oxygen saturation 92 in the room air, blood pressure 150/100, and the pulse 100 beat per minute regular. Pallor with neck vein congested, so systolic collapse, cardiac examination spatial normal, chest examination shows that the bilateral course crepitation in the middle and the late expiratory all over the chest lung field, mainly over the right lung zone and in the right mid axillary, that doesn't clear with cough. And the abdominal examination is clear. Lower limb examination, there is the glove and the stock sensory loss with lost ankle reflex and the flexor plantar response were found. Musculoskeletal is free. Lymph node, there is no lymph node enlargement with bilateral normal fundi. This is the CBC, and the SR is 92, and the blood urea is 100, and creatinine 3.1, and the blood gases 7.35 with bicarb 18, and saturation is 90 on the room air with normal coagulation profile, electrolytes, and the liver function test. And the urine analysis is reddish with albumin 3+, and RPCs 80/100 with the granular cast, and the 24-hour urinary protein with 1 gram per day. This is the ECG, shows the sinus tachycardia. This is the initial chest X-ray, shows the lower lung zone infiltrate more on the right side. And the high resolution CT, as you see, ground glass opacification in the geographic distribution, confirming the crevi-pivin appearance, which is likely the intra-alveolar hemorrhage. And the SARS-CoV-2 testing was done for the throat swab, which is negative. And he was referred here to our ICU in the investigation and the management of type 1 respiratory failure and acute kidney injury, saturation 95 on 6-liter oxygen, mask and CVB and urinary caster give only 300 cc of the dark urine produced over the 12-hour and the CVB 16. And the 24-hour after the ICU admission, the patient suffered from respiratory distress, hemoptysis again, associated with the desaturation, deterioration of the conscious level, and also mandating sedation and the intubation and the mechanical ventilation. Suction from the endotracheal intube reveals the frothy blood-tinged sputum, and saturation is 100 on the FiO2 100%, and the bedside echo shows that the normal left ventricular systolic function and the mild precardial effusion, and the follow-up of the blood test, serum potassium is 7, blood urea 120, serum creatinine 3.5, and the hemoglobin is 6, with normal coagulation profile, normal platelet count and the liver function, and also all virology and all immune screen are normal. We do the anti-GBM for the presence of alveolar hemorrhage, so it is negative, but we do the ANCA test, which is the ANCA-C, which is elevated. Blood culture and the bank culture are all sterile, and the sputum sample don't show any bacteria or TB bacilli. And we do the bronchoalveolar lavage, shows a hemosiderin leading macrophage, and the CT on the nasal and the paranasal sinus only maxillary sinusitis. And the nerve conduction velocity confirms the presence of the axonal polyneuropathy, and the abdominal ultrasound normal-sized kidney with grade 2 parenchymal changes. At this stage, what is your opinion? What is clinical decision regarding the step of management? Yes. You will to proceed to what of your decision of next step of management at this setting?
This patient, doctor, I'm sorry, this patient first has hyperkalemia, has potassium 7. This most very critical point. You must treat hyperkalemia. You can start dialysis for this patient.
Yes.
And most likely diagnosis for me could be Wagner disease because sinusitis, and there is chest problem with renal impairment.
Yes.
plasma exchange, maybe alternative. First, I will start dialysis, and there is planning to start plasma exchange plus IV methyldensilone or cyclophosphamide. But the first step, you must treat hyperkalemia and fluid overload.
Okay, thanks for your share. We will start about, we are dealing with an ANCA-associated vasculitis. What is the position of this therapeutic plasma exchange? The rationale here is to remove the cytotoxic ANCA antibody, mainly the PR3, and the indication is the presence on the diffuse alveolar hemorrhage is its category 1 with the evidence 1C. And in the presence of the RPGN, it is category 1 with the 1B. And in the RPGM with creatinine less than 5.4, it is reaching to category 3. It is differentiating because the prognosis depending upon the case that you see. In the eosinophilic granulomatous cholangitis, you are seeing about the category 3. The frequency, we do it in every other day for about 7 sessions of the exchange. But when the presence of diffuse alveolar hemorrhage, we done daily. And the replacement solution is the preferred albumin, and the plasma here is preferred to correct the coagulation defect and the presence of alveolar hemorrhage. As you see, we start the pulsosoliumidrol 750 milligram for 3 days, followed by the prednisolone 60 milligram per day with gastric and pump protection, starting the regular hemodialysis day after day, which is a very important due to the critical hyperkalemia, and then therapeutic plasma exchange second day on the admission due to the presence of the RPGN and the pulmonary vasculitis, and we do the 7th session of the exchange, and the marked improvement of the condition with the day with the fever and oxygen saturation, and let you imagine this is the CT after the end of the exchange, and there is the remarkable and disappearance of the hemorrhage, and again to do or not to do the renal biopsy at this setting after improving of the patient.
Who is to do renal biopsy? Please raise a hand. 1, 2. Not to do renal biopsy. 3, 4.
Okay. We do renal biopsy after the stabilization of the patient condition, and this is the biopsy that is removed that the 9 glomeruli, 6 of which show fibroepithelial crescents and collapsed tuft, and immunofluorescence negative for confirming both post-immune crescentic RPGN. As you see, this is the study according to the American College of Rheumatology in the 22 for the granulomatous cholangitis. This our case with the cytoplasmic ANCA-C is positive, and the second issue is the presence of the post-immune glomerulonephritis with the +1. And when this score is exceeding 5, you are definite diagnosis for the granulomatous cholangitis. And so that the cyclophosphamide is the next step, 0.5 gram per meter square monthly for 6 months. And after the first dose, the creatinine reaching 1.8, and he stopped the intermittent hemodialysis. And after the 2 months, lowering the dose of the steroid start with gradual tapering of the cortisone to the 7.5 milligram per day. And follow up 6 months. After 6 doses of the endoxan or cyclophosphamide, cushingoid facies, serum creatinine 1.1, maintained oxygen saturation, and urine examination, few RPCs, and the spot urine test is a proteinuria reaching to 0.2 gram, and he was on the azathioprine maintained and 5 milligram prednisolone, and the follow-up ANCA within the normal range. And this is the case of the GBA with the history and the clinical finding. The early detection is essential as the case is rapidly deteriorated, as you see, and the renal biopsy after stabilization of the condition of the patient, typical finding, and the high level of index of suspicions in this case mitigates the initiations of the plasma exchange for early if the AKI due to the vasculitis is diagnosed. And the second case.
1 minute, please, Ahmed. Professor Kashani has a comment that yes. They are using rituximab in this case and never plasma exchange for this.
Yes, but the rituximab, yes, it is used as a maintenance therapy, but we need as the rituximab it started to be acting after the 3 weeks or 4 weeks to starting is action. It may be used after the cyclophosphamide, instead of the cyclophosphamide after the plasma exchange. But the two rapid condition to improve the condition, it is the two issues. As it is the IVIG in the presence of the sepsis, and the plasma exchange is to be rapidly to be because the presence of the diffuse alveolar hemorrhage. But definitely rituximab is definitive, but the diffuse alveolar hemorrhage, this is mitigating and rapid therapy in the form of the plasma exchange. When to go to the case 2, this is a 21 years old male patient, not diabetic or hypertensive, diagnosed as an SLE with hematological activity in the form of anemia and thrombocytopenia, prescribed steroid to which he was resistant. Subsequently, first dose of the rituximab is given 1 month before admission to our hospital with improvement of the symptoms, and then he was discharged from the hospital. And the patient relapsed again and presented to the ER with the thrombocytopenia in the form of subconjunctival hemorrhage, with purpura and ecchymotic patches. Upon examination, the patient is fully conscious, temperature 36, respiratory rate 20, but the oxygen saturation is 92 in the room air, and the blood pressure 120/80, and the pulse 110 per minute regular. There is pallor and with purpura. Cardiac examination free, chest examination is free, and there is the splenomegaly just felt about 2 fingers below the costal margin, and there is petechiae and in the post upper and lower limb, free musculoskeletal, free lymph node, and bilateral normal fundi. Laboratory investigation show moderate anemia, hemoglobin 9.6, mild leukocytosis with absolute lymphopenia and marked thrombocytopenia, ferritin 57, Retex 2.1, and the correct absolute Retex counts 83.370, and direct combs was negative, and the fragmented RBCs is negative. All labs is normal apart from albumin is 2.6. Urine analysis shows a 24-hour urinary protein 250 milligram. ANA is positive speckle 1/30, and the C3 consumed, C4 consumed, and the lupus anticoagulant positive, virology is negative, and the pelvic abdominal ultrasound show borderline splenomegaly. At this stage, what is your opinion? And what is your clinical diagnosis and the next step of management? Yes, with consumed C3 and C4. Okay. The patient started pulse steroid, according he is lupus, and upon admission for the criticality, followed by the full dose of oral corticosteroid. Then he received the second dose of the rituximab. Here we give rituximab. This is the second dose with improvement of the thrombocytopenia from 5 to the 21. And 10 days later, the patient started to develop an attack, fever, diarrhea, flu-like symptom, persistent for the 3 days, followed by jaundice. And the patient kidney function, liver function, and the liver enzymes and INR rising. This is the graph first for the liver function, ALT and ST, and second the graph for the bilirubin, and this is the graph for the INR and the creatinine reaching to the 2.5. So we do virology again. Always negative. We do CMV and Epstein-Barr IgM, always negative. And the urine, and you repeat the abdominal ultrasound, there is a uniform hepatomegaly and the mild ascites, which is not present in the previous. We do the portal vein duplex, which is normal. What is your opinion now, and what is your differential diagnosis? Yes, yes. We put the 3 differential diagnoses. First of it, it is an autoimmune hepatitis secondary to the lupus or lupus-related liver involvement, non-autoimmune hepatitis. Drug-induced liver injury may be due to the rituximab, and the viral infection in the immunosuppressed patient. First, an autoimmune hepatitis secondary to the lupus, the following was done. Anti-LKMP antibody negative, anti-mitochondrial antibody negative, only the anti-smooth antibody was weak positive, and the serum IgG was normal, so the patient is not fulfilling the autoimmune hepatitis by this criteria, but the liver biopsy is still considered. But again, don't forget the lupus, it can cause the liver dysfunction due to the other causes, like the lupus hepatitis, vasculitis, or even secondary condition to the non-alcoholic fatty liver disease due to the long-term steroid use. And the rituximab induced liver injury. Rituximab can cause mainly by severe hepatitis through hepatitis B virus activation if it is not tested before, or other infection in the immunocompromised patient, and the viral infection, even with the negative virology, until we repeated it 2 times. In our case, the immunosuppression from the lupus and the rituximab could be due to the viral infection, especially hepatitis B and hepatitis C, which leads to elevated liver enzyme. What will you do now? Don't forget the plasma exchange for the acute liver injury, but the rationale is to remove mainly the inflammatory mediator and the albumin-bound and the unbound toxin and the restorations of the homeostasis. In the Wilson's disease, which is not, it is an indication in the acute liver injury to remove the copper. Indication in the acute liver injury, therapeutic plasma exchange, which is normal, it is evidence of the category 3. Category 3, it is case by case. It is used as a salvage therapy. But if we use the high volume, it is category 1 with the level of evidence 1A. And due to the fulminant Wilson, it is category 1 with level of evidence 1C. So that's, we are not in the 2 or 3. The frequency in the acute liver injury, it is daily until you do the transplant or clinical improvement in the patient. The high volume, it needs to perform the 3 consecutive sessions. And the replacement mainly by plasma more than albumin. And to the target to remove with the volume status, not 1 or 1.5 volume as the usual. It is 8 to 12 liter exchange in the high volume plasma exchange. So we decided to do the plasma exchange as a salvage therapy for this patient due to the rapid deterioration of the inpatient general conditions and also the elevated liver enzyme. And we give 1 volume plasma exchange with 6 sessions of the plasma exchange every other day, significantly improving and declining of the liver function. Let you imagine the liver function is improved as this, and the bilirubin is improved, INR is improved, and the platelet count is rising to 150. And this is the graph, again, for the drop of the liver function and the drop of the bilirubin, the drop of the INR, the drop of the serum creatinine, and based on the possibility of the seronegative viral infection, hepatitis B PCR is negative, and the hepatitis C PCR, it is here is positive, which is done. And so the patients, after improving, started the clatasivir suppositobar regimen, then discharged for follow-up in the outpatient clinic. And if the follow-up in the outpatient clinic, normalization of kidney function and the liver function, and the follow-up ultrasounds, there is no ascites, and there is no hepatomegaly, no splenomegaly, and only the follow-up, there is the target PCR level with the sustained virological response, and now the patient maintained on steroids, Celicept, and the Plaquenil due to the condition of his condition. So we are presenting this case to present the unusual presentation of acute liver injury and the unusual treatment with the plasma exchange. And this is one of the different series of cases that will be published from our university within the few months. When to go to the case 3, this is the 52 years old male with the primary antiphospholipid antibody syndrome for the 12 years ago, with 1 episode only of the deep venous thrombosis migraine with the persistent high titer of the IgG anticardiolipin and the beta-2 glycoprotein 1 antibody. And 3 weeks before admissions of the hospital, the patients presented with the acute bacterial prostatitis treated by the ciprofloxacin for the 2 weeks. And on the day of admission, he presented with the deterioration of the general condition with the weight loss, splinter hemorrhage, leg ulcers, and the livido reticularis, as you see by the picture. And the ECG shows that the ST segment depression in the lateral part. Echocardiography shows that the left ventricular dysfunction with ejection fraction 30 to the 35 with no regional wall motion abnormality. And the lab elevated cardiac troponin and the thrombocytopenia with the platelet counts with no fragmented RBCs and the elevated C-reactive protein. Prothrombin time within the therapeutic range, it is the INR is the 4.3, and the microscopic hematuria and the dysmorphic RBCs is 5%, which is non-significant without renal impairment. high antiphospholipid tetr, anticardiolipin, and anti-beta 2 glycoprotein 1. At this stage, what is your clinical diagnosis and what is your differential diagnosis? Yes. What will you do? At this stage? At this stage? Yes. ليه 5 دقايق؟ هم مقاطعين ليه 5 Therapy was for the catastrophic antiphospholipid, as you say, first we initiating pulse solumedrol, 1 milligram methylprednisolone, followed by the prednisolone 80 milligram and unfractionated heparin. Okay? The role of the plasma exchange here is there because there is no presence of the multi-organ affection, and there is no severity, and there is no fragmentation of the RBCs. And despite this treatment, the platelet count improve only to 16 on the day 3. And the consideration of the heparin induced thrombocytopenia here, but we do the ELISA test for the heparin platelet factor number 4 antibody, which is negative, so it is excluded. So the patient is not improving. On day 4, he developed acute hypoxemic respiratory failure. Doppler ultrasound, there is no evidence of the DVT. And the CT scan don't visualize any pulmonary opacity, and the lung perfusion shows a diffuse defect with no augmentation, with no argument in the fevers for the pulmonary embolism. And he was admitted to our medical ICU due to the severe hypoxemia, and we introduced the high flow nasal cannula, which is one of the introducer to improve the oxygenation instead of the CPAP. So that's with the 60 liter per minute in order to reach FiO2 100% to achieve the PO2 and FiO2 more than 80. But in the day 5, there is the right flank pain, and we do the CT. There is, as you see here, right adrenal hemorrhage. And they developed the acute kidney injury, rising serum creatinine 2.8. And the laboratory test done again, the rising of the antiphospholipid antibody titer. At this stage, I think the plasma exchange here is the rule. And in the caps, there is the removal for the antiphospholipid antibody cytokine, tumor necrotic factor alpha, and the complement. With the evidence is 1, but the category 1, but it is the 2C. We do daily or every day clinical response, and the replacement solution is the plasma alone or in combination with the albumin. In the view of this patient, the worsening of the general condition and the presence of the inflammatory syndrome, piperacillin, tazobactam, and amikacin was initiated. Unfractionated heparin discontinued despite of the bleeding, and the daily plasma exchange sessions started from the day 6, and the patient rapidly improving and allowing the patient for the initiation of the plasma exchange, and the successful weaning from the oxygen, normalization of the platelet count, troponin, and the serum creatinine within the 4 day. We don't continue to the 6th day, but we continue for the 6th session with 1 volume plasma exchange. 6 days after initiation of the plasma exchange, marked decline of the antiphospholipid antibody titer, all returning to the normal. And on the day 11, the patient was discharged from the intensive care medical care with the plasma exchange. We do in this case, we don't sudden stop. We do in the gradual tapering to avoid the relapsing again of the patient. And this case illustrates the difficulty for starting of the clinician for the optimal time for starting the plasma exchange with the caps. And in our case, the multi-organ system involvement, plasma exchange was delayed due to the absence of any clinical severity and the negative fragmented RBCs. And despite the corticosteroid and the unfractionated heparin, the patient general condition deteriorated, and the plasma exchange was done because of the high titer of antiphospholipid antibody. So that understanding this pathophysiology, more precise description could be initiation and identify this patient who may benefit from early initiation for plasma exchange. And this is one of our experience from the therapeutic plasma exchange and the therapeutic apheresis. And this is the second with my dear professor and dear colleague, Dr. Yasser, which published in the new, in the ERA Edita, the last one. And our take-home message, therapeutic plasma exchange contributes an extracorporeal removal of the large molecular weight constituents of the plasma that are mediator of the disease, and only the antibody cytokine and endotoxins can be removed. And don't forget, critically ill patients may have an indication for the plasma exchange that needs the other intermittent therapy like the hemodialysis, and the special attention should be affected to the medication on the critically ill patient. Don't forget this issue because it is very important. And thank you.